Even during normal use of a device, many things could go wrong. Not because a user tries something wrong, but because they do not succeed in doing the right thing. Or maybe they even do that right, but something else happens and causes a fault. For example, in traffic, even if you are the world's best driver riding a well-maintained car, you could be hit by someone not paying attention. You might get into a slip due to a badly manufactured tire suddenly exploding, or due to a tire getting punctured by something sharp that fell off the truck before you. For our electrosurgical system, we'll go through each of the phases of the intended use process that you just read about, and then for each of these phases, we will take some steps for which we'll try to come up with a hazardous situation and a consequential harm while considering the 6 aspects of the intended use. When useful, we'll indicate whether these are random faults or systemic faults. If these things do not sound familiar yet, you could review the PDF with the stepwise approach for risk management and the videos in the previous sections once more. Later in this course, we will look into how to prevent or reduce the risks that we find, but first we do the risk inventory. So let's start with phase 1, preparing the device for use. In step 1b, the user must connect a new sterile delivered handheld device, the scissors. There is a biohazard that could lead to a random fault when the user accidentally doesn't have clean hands or gloves and touches the shaft or tip of the scissors after opening the package. This may lead to patient infections. In the same step, there's an electromechanical hazard. If one of the pins of the connector is a bit bent or the connector is plugged in a bit tilted, one of the connector pins might short circuit with another or not connect at all. One of the potential consequences of this could be that at the moment the surgeon wants to cut and coagulate a blood vessel so it doesn't bleed after cutting, the device only mechanically cuts with its sharp blades, but does not coagulate. This could delay surgery and cause severe blood loss. If the pins fail due to wrong insertion, it's a random fault. But if they fail due to a bad design or production, it's a systemic fault. There is a probability for each of those, and they share the same potential consequential harms. In phase 2, connecting the patient, and specifically step 2d, it is essential that the return electrode makes good contact with the patient's skin. This is because then the area through which the current has to go is as large as possible, and thus the current density at that point as low as possible. If only a small part of the patch is in good contact with the skin, all current flows through a tiny area of the patch, creating a high current density and thus a potentially dangerous temperature rise and skin burns where the electrode contacts the skin. And if there is no proper contact at all, the electrical current loop will not be closed and no current will flow when the surgeon presses the foot switch. If the surgeon doesn't notice, the same harms may occur as when the handheld device connector fails. In phase 3, insertion of the scissors into the patient, step 3a describes that an incision of at least 10 mm is needed. If the surgeon misjudges how large 10 mm is, they may have difficulty inserting the scissors, causing these incisions to tear out. Or if the surgeon pushes hard to get through the narrow incision and suddenly the scissors pop through, organs or blood vessels may be damaged by the scissors tip, potentially causing blood loss, organ damage, or infections. In phase 4, if the scissors have been properly positioned and put in place to perform some coagulated cutting, step 4c, the actual surgical action, may go wrong with the current device. Because the foot switch pedals have the same color and are unlabeled in the current device, proper use entirely depends on whether the user remembers the instructions and has the switch in front of them properly. After all, from your position, which pedal do you press if you want to make sure you coagulate while cutting a blood vessel and not just cut it open? This situation is a typical systemic fault caused by a design flaw from a usability perspective. We can expect many users to make the same mistake simply because the designed interface is unclear. For phase 5, retracting the scissors, imagine you are having the laparoscopic camera inside the patient in a position to see the scissor jaws. That's perfectly according to the prescribed step 5a. And then you retract the scissors and they move out of the image and you see blood dripping into the image. You look at the patient and see that you were so focused on keeping the jaws closed that you squeezed the handles real tight and one of them bent, releasing the closing mechanism and causing the scissors to open by themselves. Due to that, the scissors tore a large artery and enlarged the skin incision with the open scissors. This situation occurred because of a systemic fault in the instructions. The camera should also visualize the retraction path as much as possible, not just the scissors tip. But maybe the cause was also a random fault during the retraction, material failure. Or worse, the material failure may be a systemic fault if the design was calculated too weak or the handles had a manufacturing defect. Phase 6, turning off and decoupling the device, shows once more why it is so important to consider the entire use process and life cycle of the device in your risk analysis. In step 6c, the current device interface does not help the user to know when the device is cooled down enough to touch, or that it should never be touched at the tip. So if the user touches the device too soon or touches some plastic object with the scissors if they're still hot, skin may get burned or the object may get damaged. So hopefully you have now seen how risks lure in every little corner, even when your user is on Santa's nice list and knew what to do and tried to do it right.